Hey guys, welcome back to the BirthLink podcast. My name's Colette. I'm going to be your nurse today, and we're going to dive in on the first 15. This is a series I'm going to call what we do in those first 15 minutes after birth. And that is a time period that you are probably going to be in some kind of labor or birth fog. The fog meaning a rush of emotions, hormones, exhaustion, of awe. You're going to have this new little baby you've been waiting months to meet on your chest, and you're like, what just happened? Oh my God, how did I do this? How did I do that? I did it. Your partner is going to be at the bedside, probably just as emotional, just as proud, maybe scared. Who knows? Whatever the case, it's going to be you and this baby, and you're going to immediately start that bonding process. Whether it feels natural or not, it's going to be happening. But what I want to discuss is what is happening around you during that period of time, during those first 15 minutes. We're going to get into the first minute today, actually, with delayed cord clamping. And what does that mean? Why were we just maybe 10 years ago clamping and cutting the cord immediately? And why has it taken so long to change when we've had hundreds of years of evidence showing the benefits of delaying cord clamping? Why did it take that long? What's the history behind it? So whenever we want to discuss certain practices, we should understand the why behind them in order to make our own educated decisions. This is something that you can put on your birth plan and that you can definitely have a discussion with your provider and with all your nurses that come in, so everyone understands what your wishes are with regards to clamping the cord. Are you okay with immediate cord clamping? And in what situations would we have to do that? You want to have a good understanding of that. So today we are going to dive into the history of cutting and clamping that cord and why we do the things we do. We will get into a future episode on our current practices and the evidence behind it. I touched on it a little bit today, but we'll get into it more in an episode coming up. And I'm also going to include cord blood banking and cord milking. I don't know if you've heard that one, but that was pretty interesting as well. So I'm going to touch on those in a future episode. Today is just the history, and I'm going to touch on what we currently do so that you can get started on understanding and start with that discussion with your provider. Super interesting. I love it. Again, if you want to come to my birth plan workshop, I hold those every Sunday. They're completely free, and I welcome anybody and everybody. So just find me on Instagram at My Friends a Nurse and let me know that you want to join the workshop on Sunday. I'm in California, so it's Pacific Standard Time at 5 p.m. If things change, if you're listening to this a little later, then that time may have changed, but I love these workshops. I plan on continuing them. So please message me and come join me, and I can give you the inside secret tips and tricks to making your birth plan work. So as much as we want to go into how do I make a birth plan, I think it's a lot of research and taking a great childbirth class, maybe like mine. I have one in August coming up, September, October. Just find me, myfriendsandnurse.com. I will have all that information. But as much as it goes into researching it, it's how to use it. So these workshops are really important, and I would love to have you join me. So you can go to My Friends a Nurse and get the link there to join, or write me on Instagram, Facebook, Colette at My Friends a Nurse. If you want to email me, you can find me. And I love to chat, and I would love to get to know you. But for today, anyways, we are going to dive into a little portion of your birth plan, delayed cord clamping, and the history behind it. So let's get into it. Welcome to the BirthLink podcast, presented by My Friends a Nurse. I'm your host, Colette McCollicker, a high-risk labor and delivery nurse right here in sunny California. I'm also an OB certified specialist, birth educator, lactation expert, and mother of 2 beautiful daughters. I am passionate about guiding you through the miraculous journey of pregnancy and childbirth, using evidence and history and asking the reason why. I have some incredible medical friends and colleagues, and we're all here to help you navigate this often overwhelming birthing hospital system in the United States. My goal is to gain trust in birth, improve this system, and provide some valuable insights. Let's make this journey a little less daunting and a lot more joyful. Let's get into it. Welcome, guys. So, this episode, we're going to talk about delayed cord clamping and cutting and what's going on. What's the history of it? What is our current practice? What's the evidence show? And what is the reason behind why we do the things we do? So, you may be pregnant and start hearing around town about delayed cord clamping. You may ask your doctor, do they delay the cord clamping? And they'll say yes, about 60 seconds is all you need, or they'll just say yes and they won't tell you how long. But I'm here to tell you that most likely it's about 60 seconds unless you request otherwise, or you just happen to have a provider that waits maybe 2 to 3 minutes or until it stops pulsating, but that one's rare. And we want to know the why behind it. Why are they waiting 1 minute? Why would they want to wait 2 to 3 minutes? Why would you want to wait until it stops pulsating? And what did we used to do and why? So let's get started with first what's going on. What's going on with the cord blood, with the baby, with the circulatory system, and why would we? Then we'll intersect of why we cut the cord in the first place. So your baby has a certain amount of blood circulating in a system at any one time. The used non-oxygenated blood is leaving out of his body through an artery, and the fresh, clean, new blood with all the nutrients and oxygen is coming in from mom. There is some blood waiting in the wings and the placenta, and some traveling through the veins to the baby, and the blood vessels to the baby, and the veins. Uh, by the way, side note, this is the only part of your body and time, that umbilical cord, where the veins are carrying oxygenated blood and the arteries are carrying the non-oxygenated blood. So it's usually reversed in our system. Normally, it's the other way around. So just side note on that. But anyways, the mother is continuing to supply baby with blood. So continuing to pump blood to the placenta and to the baby until the placenta starts to separate and the rest of the placenta blood is drained into the baby. So mom's blood vessels don't know. They don't get the memo that they're done giving blood until the placenta is totally separate and is out, allowing the uterus to contract super tightly. And as a result of this, it's a result, of the rush of oxytocin that we experience immediately after delivery, especially if the baby is placed right on us and we can touch him and hear him and smell him, or even if we see him, we get a or we get a quick infusion of Pitocin, either through an IV or an injection. So that uterus clamps down really tightly and it pinches off those blood vessels so mom doesn't continue to bleed. So let's get into the history now that you have a little understanding of that cord blood process. Let's start with cutting. In most ancient primitive cultures, the cord was not cut until way after the placenta was delivered, even hours after. They have lotus births. If you've heard of a lotus birth, they never cut the cord. Instead, they wait for the umbilical cord to separate from the baby, and that usually takes about 3 to 10 days. Commonly, though, it was cut hours later when it was no longer functioning. There was no blood going to the baby. There's no blood coming away from the baby. The placenta was dried up. It was unused, and it was still attached to this white, flimsy, unused cord that was still attached to the baby. When the umbilical cord fell off naturally, that was how it was removed. It's unclear, though, when this practice had changed. The earliest record of cutting the cord before the third stage of labor. So that's what I really want to get into. Is okay, so midwives, maybe in the 1500s, 1600s, and even before, all over the world, they would just deliver the placenta. Mom would clamp down with her own rush of oxytocin. Baby would be attached to the cord. Then hours later, when it was done being used, they would cut the cord, never having to really even clamp because baby's blood vessels were closed up and so was the side of the placenta. It wasn't a big mess. Done. Then things started to change most likely around the 17th century, where, okay, the third stage of labor, that's when mom is delivering the placenta. So, first stage is actual labor, contractions, moving the baby down. Second stage is delivering the baby. And third stage is delivering the placenta. So, why are we clamping and cutting before we deliver the placenta? And that's common practice now everywhere. And earliest record of that, and it's unclear why we started doing it, but the earliest record of it was in the 17th century, and it was suggested that it had accompanied the emergence of male midwives. Yes, this practice had increased having women deliver on the bed, on their back, with their legs up. I heard, it's King Louis and all of these things, but it became super popular all in the UK and in the United States and everywhere for women to deliver on their back with a male, either a doctor or a midwife, and then it continued into female. But what happens is that it's increased, well, it limited spontaneous birth of the placenta because it took away gravity when we're laying on our back, right? And side note here, I have a little story. I had been called to a home birth. She free birthed her baby, meaning no doctor, no nurse, no nothing, no midwife. She just was at home and she delivered her baby. That's how she wanted to do it. I don't recommend it, but that's how she did it. And she called me. I was just a friend. I wasn't in labor and delivery yet. And I came over and she was sitting in the pool, kind of scared and worried. She's been sitting in the pool for about 45 minutes. And she said, my placenta isn't coming out. I don't know what to do. And I just said, stand up, just stand up. And she stood up and the placenta fell right out, splash into the water. I was like, oh, there you go. Just needed a little bit of gravity. I didn't want to pull on it. I didn't know what was going on. I was like, if it's not coming out, I may need to call 911. But why don't we just try standing up first? And it came right out. It was already expelled. It already separated. Her uterus was already clamped down. It was just kind of hanging out in the vaginal canal. And so that happens because of the lack of gravity. So because of that, because the placenta wasn't able to really get removed and it was just hanging out in the uterus wasn't able to contract. So more women were bleeding, hemorrhaging, because the placenta was left in there. So they needed to start going in and manually extracting the placenta. And before the uterus closed, or even the cervix started closing, and then the placenta was trapped in there. So there were writings that show as early as like 1668 that they used to tie they called it a neonatal tie or a clamp. And they would do that because they needed to separate mom from baby, essentially to keep the baby from bleeding to death after they cut the cord. Because now they wanted to cut the cord quickly so that they can go in and pull the placenta out and handle the baby. Not sure why. Poor babies that they learned on, because if you cut that cord too quickly, that baby is going to lose blood through the umbilical cord. Awful. So they had to, they learned probably real quick they need to tie if they wanted to cut that cord. Hopefully the mistake only happened once, but the two other reasons that they found for clamping the maternal side, so we know why they clamped the baby side, but why were they clamping the mom side? Well, one, they wanted to tie it so that they can see and it would alert them when the placenta detached, because the cord would lengthen from out of the vagina. So it would just get longer. And they'll say, oh, it got longer. The placenta's out. Now we can pull, because they were probably pulling on it and the mom was just hemorrhaging, because remember, that blood is continuing. Those blood vessels are continuing to supply that placenta that they don't even know is there. So it helped them understand when the placenta was detached. The second was to, quote unquote, spare the bed linen. So they wanted to keep it from getting spoiled by all that blood that was leaking out. So they probably learned quickly, okay, it gets messy if we cut the cord and it drains out. Nowadays, we would not cut the maternal side because maybe you're collecting cord blood. And we're going to talk about that in a later episode, why you would want to collect that cord blood. Otherwise, you can clamp mom's side. Dad or partner or doctor will just cut right in the middle and separate baby from the placenta. And then they can wait to see when the placenta is coming out and if they need a little bit of traction to help it kind of come out of the vagina. When they do put traction on it, they're not pulling the placenta away from the uterus. They don't want to separate it, but they just want to see kind of like that little neonatal tie when the placenta has separated. So they'll pull just slight traction to see if it's just going to come right out of that vagina, right? That's kind of like me saying stand up. Same thing, because most people are delivering on their backs instead of standing up or on fours or whatnot. And you're tired. You're really tired. So probably in the back is pretty comfortable after a long labor anyways. So what are you going to do? So neither of these, though, reasons to clamp mom's side was a good enough reason. But because of convenience, that wins, it became routine. So about 100 years later, some experts started warning that clamping and cutting the cord too soon had no good reason to be done except for custom. And we see that today in so many practices, right? So many things that we do in medicine is more of routine, because we've always done it that way and not so much evidence-based. And we have done this so long. We have, for their own reasons, for different reasons, we have continued to cut immediately, thinking that mom was going to bleed and baby was going to be supplied too much blood, that it didn't need all that extra blood that was not in his system. It was going to cause an increase in red blood cells, an increased chance of jaundice. They didn't see any good reason, and they didn't have the evidence behind it. So they would clamp, cut immediately after birth, and then wait for the placenta to be delivered. Around 1800, there's a researcher named Aramus Darwin wrote, "Another thing very injurious to the child is the clamping and cutting of the navel string too soon, which should always be left till the child has not only repeatedly breathed, but till all pulsation in the cord ceases, as otherwise the child is much weaker than it ought to be. Experiments have proved this to be true about 100 years later." So he's saying, let's go back to the way we were doing it, and maybe not allowing the baby attached for hours, deliver the placenta while the baby's still attached. He was still saying, okay, we can cut it, but we need to wait until it stops pulsating. It still was continuing to get popular though. Like they're just, let's do this. Let's separate baby. We'll go wash the baby. They'll handle the baby, and then we will handle mom. So they're all about separating really quickly before it ever stopped pulsating. So usually just right away, they didn't see the benefit and not. It was advised to clamp the cord when it has stopped pulsating, but the discovery in 1938 of placental and umbilical cord blood, and that it was a new transfusion blood source, became known and so popular. So now, on top of just being convenient and routine and not understanding any benefits, now they wanted to collect that cord blood. So that baby was definitely getting clamped and cut, and mom was unclamped, and they were collecting that cord blood because it was a very fruitful type of transfusion blood that they didn't want to miss out on. So cutting the cord and then unclamping mom to catch that precious blood was used for a very long time, and even today. From around the 1940s to the 1960s, more information started coming up, negating the reason behind immediate cord blood clamping for the baby's benefit. But at this point, it was just too routine to change. So now here we connect a little bit at this point with last week's episode, or actually 2 weeks ago, about Virginia Apgar. So I spoke a little bit about Virginia Apgar, Dr. Virginia Apgar, and how she created the Apgar score. So I just wanted to tie it in here just a little bit, because it's just interesting to note that in her paper in 1953 about the 1-minute Apgar was studied not only on babies whose mother was just given lots and lots of depressive morphine, but also babies that were all clamped and cut immediately. So I wonder if that also didn't help things out for baby to catch his first breath a few times and get that little bit of extra oxygen and blood and iron and red blood cells, all of it, before we're testing on how well he's doing in transition. So the first 1 minute in her studies was determined after the cord was clamped. Her paper in 1958 implied that keeping the cord intact, quote unquote, contaminates the sterile field. Delayed cord clamping is deemed a part of a, quote unquote, slow delivery, suggesting that it's unwise and unnatural to cut the cord immediately. To delay the cord clamping. Other studies, though, have showed inconsistencies, showing no significant difference in increase of red blood cells in bilirubin. Later, they found out that there is a significant increase in babies with too much red blood cells when cord blood was delayed, but not dangerous. And then another recent review concluded that yes, delayed cord clamping does increase polycythemia and hyperbilirubinemia. So that is an increase of red blood cells in the blood and of bilirubin. And it does, despite that, have an advantage. The baby is improving iron stores by 75 milligrams. So lots of conflicting data. Dr. Apgar, bless her heart, was like, this is inconvenient and we don't see any good reason. It's just going to make a mess, all this blood just waiting around. We don't have time for that. We need to get this delivery done. Just waiting around starts increasing mom's risk of hemorrhaging because we need that placenta out. So let's separate them, get baby onto, doing the Apgars and helping them out because they weren't doing well with all the morphine, right? So they don't want to keep them attached. So it's unsafe. And I'm sure with all that morphine and all the influx of medical intervention, it wasn't safe. So I see how cutting the cord quickly could have been safer for everything they were doing, right? So now today, so they have moms delivering. Okay. So they have moms delivering on their back. They're cutting the cord early to collect the cord blood, but the placenta isn't being delivered fast enough. Maybe they're separating her and baby, robbing her of the oxytocin rush. So we're giving her Pitocin and other uterotonics. Those are medications that will create contraction on the uterus. It's really, really tight. Remember, I talked about that. And then expel the placenta out faster. So those drugs are making the placenta come out real fast and maybe adding a little traction to remove it before the opening of the cervix gets really too small. And we call all of this active management of this third stage of labor. Okay, so if you're going to talk to your provider, your doctor, ask them, what is their standard practice with regards to management of the third stage of labor? Is it active? Or is it spontaneous? Are they allowing the body to just do what it needs to do? Most likely, it is active. In the hospital, we are giving Pitocin. They're clamping and cutting the cord, depending on what you want. If you want cord blood collection, if you're going to collect it and bank it, then they will be cutting it at least maybe 30 seconds. 30 seconds or less to collect as much cord blood as they can. 60 seconds, probably not, because 80% of that blood is going to be going to the baby. At around 30 seconds, you have about 67%, if I remember correctly, getting to that baby. So that leaves you about 40% that you can collect. So 30 seconds is usually what I see. So anyways, all these things that we're doing just stacked on one top of one on top of the other is causing the next thing to need to be done, if you get my drift right now. So, all right, so more and more. So we're in like 1950s right now. During the 20th century, this whole 20th century, more and more evidence is coming out ruling that maternal hemorrhage is a risk factor for delayed cord clamping. If we delay it, that placenta can't come out because she's laying on her back, then higher risk of your uterus not able to contract. So they need to get the baby out faster. So they're just like, yeah, the longer we delay it, the higher the risk. The increase also in C-sections is probably another reason why more babies were being separated early. And it's just obviously easier for surgeons to remove the baby quickly and hand off to the nurse and then go right back to the surgery, right, to prevent infection, bleeding. They'll probably give you a list. But in the last 50 years of the 20th century, the C-section rate went up from 3% to 21%. So if that gives you a little indication of why more and more babies were getting cut immediately. And I wonder the repercussions of that. Is it a huge change or not? I don't know. We don't know, but we'll find out, I'm sure. The other reasons for it becoming so popular is obviously what we mentioned: cord blood collection, episiotomy, so having a risky delivery and needing to cut mom's perineum open and helping baby come out. Well, that cut is bleeding. So they need to get to repair immediately, and they need to have that uterus, have that baby separated, and have that placenta out as quick as possible. If baby's having any trouble breathing, which as we know with the morphine and such, or just having a tough delivery, we're going to have to take baby over to start resuscitation as quickly as possible. And the last one is convenience. So, what was convenient for the doctors to move this delivery along? A lot of doctors don't want to sit and wait 30 to 60 minutes for the placenta to come out or baby to be separated. And they're not going to wait out, for sure, they're not going to wait for placenta to come out before cutting, because they just, all those other risks of mom bleeding and then having to just sit there. They have to cut it. So they're really not going to be, I have not seen that. They won't do lotus births in the hospital, at least from what I have seen in my traveling. But let me know. You write me if you had a lotus birth in the hospital, if they let you deliver the placenta before cutting it. That's crazy. I want to I want to hear about it. Okay, so with all of that, and with it being so hard to change practice and routine, we're just like sticklers for what we know, and not even when we know, it's just so hard to get like a whole system to change. It's all of a sudden more and more evidence started coming out showing that delayed cord clamping is actually beneficial to the baby. It was started probably around 2009. Only about 50% at that time occasionally used delayed cord clamping. It was just a slow roll. It's a slow roll, you guys, to do anything. So today it's more common practice, thankfully. 2024, we have got the memo that baby getting an extra 80% of the blood, waiting 60 seconds at least, is going to improve iron storage. And that is so important for babies to get good oxygen, to breathe, to get the nutrients they need. Yes, the risk of a higher bilirubin is there. So jaundice is a little bit more common now, but for the most part, mild, and babies recover very quickly. So now we have some new recommendations through ACOG and the WHO that waiting about 30 to 60 seconds after the birth to clamp for babies that are born without complications. And even the WHO actually recommends waiting 1 to 3 minutes or longer. It is not recommended if the mother is hemorrhaging, the placenta is abnormal, or the newborn needs immediate medical care. Then it's immediate. The benefits of extra iron and is just not worth it. You always have to weigh out the benefits and the risks. So now that you know the history, next week we are going to get into the common practices. So what are they doing? We kind of mentioned it, waiting 60 seconds. But why would we want to go into delayed cord clamping longer than a minute? 2 to 3, 3 to 5, or until it gets white and stops pulsating. And that really is probably around 5 minutes or so. What do you think? Send me a message, write me if you're considering delayed cord clamping. We're going to also talk about the cord blood banking on that episode as well. So just really, really love these topics. I love getting into the history of it and why we do what we do. I hope you enjoyed it. I hope you enjoyed this episode and the history behind cord clamping and cutting and why we do the things we do. But why does it take so long to change things? And why don't people ask why more? Especially providers, nurses, and patients. Like, a lot of people just cut immediately, and they knew, like, we understood 20 years ago, we had the evidence. So why were we still doing the things we did? It's a question. I don't know. Still trying to figure it out. But always ask why, guys. We're going to, like I said, get into a little bit more of today's practices on cord blood clamping. And I'm going to get into cord blood collecting and cord milking. Have you heard of that one? I don't know. I have, but I loved getting into it more and learning the latest up-to-date medical evidence on cord milking and what your doctor knows and what you should know as well. Next week, we are going to have a wonderful conversation with Dr. Jocelyn Rodriguez. She is a physical therapist, but more importantly, a pelvic floor specialist. So we are going to dive into great pushing techniques to lower your risk of tearing and complications, hemorrhoids. And it kind of starts with how we poop. I don't know if you know that. Did you know there's a possibility you're pooping wrong? Yeah, neither did I. But she jumps into that topic, let me tell you. It's really, really interesting. It's how we teach our kids how to go to the bathroom, and it's how we go to the bathroom, and then how we use those same methods in pushing. We will also dive into recovery and certain things that we need to know to advocate for ourselves in the labor room. So I can't wait for that episode next week. I hope you join me. Thank you again, and I will see you soon. Thank you for listening to My Friends and Nurse presents the Birthling Podcast. We hope you enjoyed today's episode and found it valuable. Before we go, a quick reminder. The information shared on this podcast is for educational purposes only and should not be considered medical advice. Always consult with your healthcare provider for any medical concerns or questions. If you enjoyed the episode, please subscribe, leave a review, and share it with your friends. Your support helps us reach more people and continue to bring you great content. Until next time, stay healthy and stay informed.